All right, we're all still here, so that works. Here we go.
Dr. Entwistle, how's your day going today?
It's good, thanks. Yeah,
Good.
thank you very much. How about you?
It's going well. I'm happy the weather's holding up here.
It's slightly cooler for us here in Northern California. It's still warm, but it's not hot.
What is
Warming up
hot
nights
for
like this.
you?
Oh, 90 can get up to 100.
Okay, okay. That's about what it's taking out here. The 80s,
Yeah,
not too
that's
bad.
pretty normal in the Midwest. 90s, 100.
100% humidity.
Oh my gosh. The last week has been nuts. My hair is just everywhere.
I, my hair just drinks it up. But it looks
We
like
can give everybody just another minute to join, and I will talk about this first slide and then I'll turn it over to our presenters. But while you're waiting, if you'd like to obtain your CME credit, please do so. Thank you. Okay, everyone, we will go ahead and get started. Thank you so much for joining us today. We have a great presentation for you by Dr. Hoff and Dr. Entwistle. I just wanted to give the information for obtaining CME credit. Please note that you must create an account through the University of Arizona Cloud CME platform. There are 3 ways to submit attendance for CME credit. That is through texting the attendance code, through the mobile app, or through the online attendee portal. Also noting that if you would like to obtain ABIM MOC credit, you must complete your full profile one time before submitting attendance to receive the credit going forward. Today's attendance code is 55177, and we will drop that into the chat just a couple of times before the end of the program. And just as a reminder, you have 24 hours to submit for CME credits. So with that, I'll turn it over to our presenters, and thank you again for joining today.
Hi, welcome everybody. We'll be talking today about closing the rural stroke gap. I've got my partner here, Dr. Martin Entwistle, if you'd like to introduce yourself.
Yes, hello everyone. I'm Dr. Martin Entwistle. I'm Chief of Medical Affairs at Marshall Medical Center in Northern California. We're a 111-bed rural hospital, secondary level care. We do provide stroke and general neurology. And we'll be telling more about some of our challenges and opportunities in closing the gap in rural healthcare stroke management.
And I'm Dr. Caitlin Hoff. I'm a third-generation South Dakotan, currently working as a vascular neurologist and neurohospitalist at Vera McKinnon on the ground, and I'm also working with Savaro, and excited to talk about this topic that's so near and dear to my heart. So here are disclosures. I do work for and with Sabaro Health, and I don't have any conflicts of interest, and Dr. Entwistle also has no relevant conflicts of interest. We won't be using any brand names or services during the talk. So our objectives today are really to go through that patient experience and just compare how different the stroke care can be here out in the rural counties. So it'll start with identifying the rural stroke population and then the changes or the unique circumstances under which the patient gets their care all the way through going home. So defining rural America, I really like this graph because it shows, almost 90% of the US is considered rural, which is a non-metropolitan county with less than 50,000 people, and it makes up about 20% of the US population, or around 65 million people. Medicine looks much different here in rural America. For physicians per 10,000 people, in urban counties, that's about 31 physicians or primary care physicians per every 10,000, where in rural counties, it's only 13 for that same number of patients. Specialists, the gap widens even further. In urban counties, there are 263 specialists per 100,000 people, where in rural counties, it's only 30. There's a higher population over the age of 65 in rural areas. People are also more likely to smoke, more likely to have hypertension, and there's actually a 3-year less life expectancy. The hospitals look different too. About a third of hospitals in rural counties are considered acute care hospitals. And of those, 60% are critical access beds with less than 25 inpatient beds. I know that this is the majority of the hospitals that I work with, and I've had the opportunity to rotate at some of these hospitals throughout my training, and it looks different. The person getting labs is also getting the CT scanner turned on, and there's often just one provider. Sometimes it's an APP, sometimes it's a physician, and there's really no backup. So I spoke a little bit about what the critical access hospitals look like in South Dakota, and those are the majority of the hospitals of which I serve right now. In your neck of the woods, Dr. Entwistle, what does that look like? What is your hospital system made up of?
Sure. Well, happy to talk a bit more about that. As I mentioned, we're about 111-bed hospital, so we're providing a range of services. We've talked about neurology. We're a primary stroke center, cardiology, internal medicine. We provide a range of surgeries, so general surgery, orthopedics, podiatry, urology. But then we don't have, for example, vascular surgery, so stroke management, mechanical thrombectomy we wouldn't do. In the cardiology area relevant, we don't do stenting. So we fairly rapidly end up with patients we have to transfer out, and I want to talk more about what that means. First off, we're not providing all the services that may be required. Patients are having to travel for significant distances, and then maybe we end up with their ongoing care being removed from their community. So I'll talk a little bit more about it if I can. So I think overall, and you probably have the same situation, Dr. Hoff, this is maybe compounding as we go on and services are decreased in rural areas, i.e. there's a bigger chance you're having to transfer patients out. So for us, the big focus is on what can we do to provide care in the community. One key issue is access to specialist care. I've been touching on that in the inpatient setting, but right now we have challenges in the outpatient setting and close to home in relation to neurology. I'll give a bit more detail as we go through, but we have no neurologists in our county, which means even for outpatient follow-on for a stroke patient, or in some ways even more importantly for ongoing care for general neurology, whether it's epilepsy, whether it's other general neurology conditions, we're referring out to our biggest local city is Sacramento. That's about 40 miles away. Doesn't seem that far from the hospital, but if you think that if we go further east into the mountains in the Sierra Nevada, travel times can be 3-4 hours, and it's difficult. So for that patient who's had a stroke, transportation difficulties, that compounds, the very issue we're talking about. So related to care in the community, obviously in some situations we do have to transfer and get tertiary level support, but it would be great to make sure those patients are returned to us for their ongoing care in the community so that we can share care, and that can be something of a challenge. And also that our patients can utilize our ancillary services. So for example, we've pretty robust imaging in terms of MRI, CT, but once a patient has gone to a tertiary center, then their imaging, etc., quite likely is to be referred there at the tertiary center, which again means people are moving to and fro when we could be supporting them in their community. Another important area is how do we provide ongoing continuity of care, keeping patients under oversight rather than just episodic care. So I think, in this day and age, that means telecare for patients so care can be provided at their home, but also our ability to track. So in the neurology area, ability to mobilize, gait, risk of falls, maybe prodromal epilepsy, etc. There are all sorts of things I think we can do and should do to be better getting insight to our patients and be proactive in supporting them to have their care in the community, not wait until something happens. So in the tele area, the issues around site of service, forced to bring someone to a clinic as opposed to being able to provide care in the home, that can have an impact. And then, of course, the elephant in the room is getting paid for this. So sustainability of the services at current reimbursement rates is a challenge. Marshall is not a critical access hospital, and so we don't get the benefits of some of those rates. One of our clinics is a rural health center, so we do get beneficial rates for government programs there, but that doesn't apply to all patients in all the areas that we serve. I think the other big area, of course, is staffing. We'll be talking a bit more about this. So recruitment and retention of providers, that's partly why we don't have an outpatient neurologist. People are unwilling to be the sole provider, which might have been the case in the past. And then the economics of having a team of providers is challenging. And it doesn't just stop there, because it's also our nursing staff, our ancillary staff, providing pathways to recruit and retain important. The next slide. So I've touched on some of these, but these are the kind of challenges. We've talked about the limitations on access to outpatient services, so close to home in neurology. It may take us 3-6 months to get an outpatient appointment for neurology in the Sacramento area. That's a long time to wait for somebody that's just been discharged from an inpatient setting. We've talked about the travel. We've talked about inability to provide the ancillary services because the patient is captured, if you will, by the tertiary level. Some other issues in terms of just general operations, be able to provide the services, having the equipment that somebody may need in their home, DME, etc., to support post-stroke, all challenges. So those are things that we're working on, and you can see over on the right-hand side of the slide, I won't run through all of those, some estimations of what improvement we could make, which would be material if we could address those things. Next slide, please. So we do have a concept for how we might improve this, and probably a number of people on this session might have heard about hub and spoke models. So the idea is that by clubbing together, if you will, between facilities that maybe share the same kind of challenges, so different hospitals in a rural area might collectively have resources that no one has got, or if we work together, for example, it may be possible to then recruit a neurologist or team of neurologists if we share them between all of us. It isn't just hospitals, because that can include clinics, post-acute support, etc. And I want to call out that, of course, we do need to be partnering with tertiary centers. I don't want to give the impression that we can do without them. We absolutely can't. But how do we make this part of this more collective, collaborative delivery model, a rural health network, if you will, that can fill the gaps, provide support? And we're excited about the potential in this and are working actively right now to see what we can do. And I'll talk a little bit more about that in a minute. Next slide, please.
And if I may, this is the model that our hospital system is also working towards. So I'm at the tertiary center, but we do have regional kind of hub centers identified. But I hear you, and how is that implemented? What does that look like? I just think this is very interesting. Sorry.
No problem at all. I'll just give one example. So it isn't neurology, it's behavioral health. That a couple of years ago, we weren't able to retain 2 psychiatrists that we had. And so you can imagine the impact of not being able to maintain that service, really big impact, not dissimilar to neurology. What we did is we partnered with a federally qualified health center nearby because they got better reimbursement rates. And so actually we refer for our outpatient behavioral health and psychiatry. We partner with them and refer to them. So we have an example of how you might do this. That is an example of hub and spoke. This situation for neurology, we kind of want to be the hub to help bring patients in, but it gives you an example of how it can work. And that's been running for about a couple of years, pretty successful. So one of the exciting things, again, I think many people will know, have heard about the Rural Health Transformation Program. This is under the One Big Beautiful Bill with $50 billion put into states by the federal government and spread across different states. So I'm in California, and California has been granted about $234 million out of this program. And you can see in the slide the different areas of focus. Focus on rural health, sustainable access, workforce development, innovation, and technology. And that's actually all the things I've just talked about that are challenges for us. So we're very actively working, as many others are, to put proposals into our state government, actually focused around the hub and spoke model that I've talked about. And our focus is neurology. So we're excited to see if we can bring into play a model that would help us address the issues that we've been talking about. Next slide. So the big areas for the California state government are workforce development, retention, training, maintain both providers and other staff in the community. Transformative care, we've been touching on that as a different disruptive model to the way we think about how we deliver care, and the technology and tools that are really important. So telehealth systems, etc., the ability to monitor patients in their own home, how are they doing? Next slide. And so this is kind of the bottom line. We're excited for the reasons I say, that we think this will help us create a transformational model that directly addresses the challenges we've got. Now, it'll take some time to build. The Rural Health Transformation Program is year-on-year funding over 5 years, and it'll probably take that long to get there. So our aim is to start small. Can we just tackle the outpatient neurology and create a model that we could then diffuse both to other people in our network? And we're also hoping that we could develop a model that other people could pick up and adopt if it might work for them. So it isn't just about us. It's about creating a model that others can assimilate, if you will. Next slide.
So that takes us back to stroke in these rural areas. Throughout the US, stroke is the 5th leading cause of death, and the incidence is actually higher in rural zip codes, about a 30% increased risk of stroke, and with it comes less access to care. Patients in rural zip codes are 50% less likely to receive thrombolytics, 12 times more likely, or less likely, I apologize, to get thrombectomy, and have actually a higher case fatality rate. These delays start at home. There's longer wait times to calling 911 or to even getting to the hospital. they're less likely to arrive within the window, and EMS is utilized only about 50% of the time. I really like this slide. This is, it highlights the areas in black. It's more than 60 minutes to get access to a thrombectomy capable center or a comprehensive stroke center. So I am right here in the yellow, and Dr. Entwistle, my geography is awful. We're over here.
Pretty much.
Uh,
Good job.
Working on it. I need the states outlined a little better. But how far are some of your counties that you serve to get even access to an emergency department? I know within rural South Dakota, it can be over an hour just to get to not an acute stroke ready hospital, but just to get to an emergency department here in kind of what I call the pretty part of South Dakota. It can be over an hour just to get access to a critical access ER. How far are some of your counties?
Yeah, we're pretty much serving one county, but you know, there are rural areas that it can take an hour and a half. There are rural areas that it could take 2 to 3 hours, and they are windy roads. We have got some very big river canyons, which means you've got to wind your way down, you wind your way up. So it's slow travel, even though the direct distance line may not be that great. And we also have to factor in the winter, we have snow. So that makes the driving, in some areas they're cut off. You wouldn't be able to travel in by a vehicle or a truck. So that's a challenge as well. So we add in the terrain, the weather, etc. It's a challenge.
In those circumstances, do you rely more on fixed wing or helicopters? Or is it just whoever's able to fly when you're in poor weather?
Yeah, I mean, we also have support from sheriff's departments that, you know, they're really important in rural communities, not just for law enforcement, but supporting the community. So in some areas, they've got snow track vehicles and can get to some outlying places. But, you know, you imagine the thing you're talking about, you know, when you're calling, you know, potential stroke, getting to them, getting them out, getting them to hospital, that's a significant limitation.
Absolutely. I hear you on the weather limitations. While most of South Dakota is pretty flat, we get some brutal snowstorms and we're not able to fly or drive sometimes. My favorite example is just as you said, highlighting how important, you know, the sheriffs can be too. One time we had to call the sheriff to get the snowplow out so we could try to get the patient to our hospital faster. It's amazing what people do when they come together, and I know that's why I work where I do. So in that transportation, the AHA has come out with guidelines for EMS specifically to help make this process happen faster. This is not dedicated to rural areas alone, but EMS guidelines for everything throughout the country, involving, you know, pre-notification, so that way people are there and waiting, and then some other factors, you know, again, just to try to make that process happen faster once they get to the hospital. What I find most interesting, though, is that dispatch time, the goal is less than 2 minutes, and the goal for arrival on scene is less than 15. I don't know about you, but Dr. Entwistle, but dispatch time less than 2 minutes. If we've got a volunteer crew and they're all at the T-ball game, that's hard. It's hard to get those to hit those metrics.
It really is, yeah. You know, another issue that EMS faces, and I'm sure it's the same for you in South Dakota, is they have to decide where they're going to place their rigs, their ambulances, and they're constantly moving them around. It's because they're having to guess where is it going to be needed, and it depends on, you know, what happens is one ambulance has been called out to deal with some emergency. They might have to move them around in order to be better positioned, because it depends on how many are actually available. So it's quite a challenge for them to organize how they're going to be placed in order to give the fastest response time.
Is your EMS, are they paid for by your hospital system? Are they volunteer? What is your EMS crew? Who's made up of that?
They're largely county employed. So we have our counties divided up into different sub-regions, if you will. And largely it's county organized. A joint powers authority called the JPA kind of organizes the oversight. So that's for our emergency. We do have some commercial ambulances that may help us with transfers, but they don't do primary pickup from home to bring people to the hospital.
So you don't have to interface much with the volunteer crews?
Some of them are volunteer crews, but we're
Okay.
lucky that we're reasonably resourced by permanent crews.
Our county and those immediately around us are served by a third party group that serves the comprehensive stroke hospitals here in my town or city. But outside of those two counties, there are a couple that are hired by either the county or by the hospital, but the vast majority of South Dakota is served by these rural EMS crews. And I just have so much respect for them because they are leaving. Sunday when I was on service, the patient collapsed in church, and the volunteer EMS crew was actually there. So their response time was fantastic, getting them to the emergency department. But we're not always that lucky or unlucky, however you want to see it. Sometimes they are, at their kids' t-ball games. That's the one I get most often this time of the season.
Yeah.
So within those AHA compliant EMS transports, only 2% are compliant with the most ideal circumstances. That's compared with 11% in urban EMS. So we have a long ways to go in all areas of the country, but 2% I just thought was a number that kind of blew my mind. There's some data to support that actually rural EMS is better at pre-notifying and getting people kind of going at the hospital down the road, which I thought was fantastic. Though that data is pretty controversial. There's a paper out of the North Carolina EMS data that found that the rural counties were less likely to get pre-notification, but overall it seems like the trend is more likely. And we know that if the hospital's pre-notified, the transportation times are lower and we have a shorter door to needle time because everybody's there and waiting to go. The AHA recently came out with a rural recognition pathway for hospitals to get recognized because, as we've talked about multiple times before, rural hospitals wear just more hats. So it's not that patients are getting less care, or it's just that the care looks different, and we need to account for that. So this is a nice set of goals, to try to achieve that. So again, we're always striving to get shorter door to needle times and get the patient care faster, because every minute we wait is 1.9 million neurons that are dying.
Dr. Huff, can I ask you a question? Yeah. What are you doing about education because one of the things you can do to make a difference is if people are sensitive to onset of a stroke and then get assistance fast as possible rather than waiting till there are maybe florid signs. So it's something we're talking about. How can we more broadly educate the population in order to assist with that? Because that's a good way of buying time in terms of these transportation challenges. So I'm interested in what you're doing.
Yeah, it's I hear you. We're struggling with it too. Since we have a unique patient population here in South Dakota, every year when the pheasant hunters, come into South Dakota, the state kind of livens up a bit. And so we do a lot of our stroke push that time of year in the fall. And so at the airport, we have booths, with door to needle information and stroke education. My personal favorite are strikeout stroke nights at T-ball games or at our, local baseball team. But I hear you, it's a struggle. At other places, we've done like a cycle out stroke, but trying to meet the people where they're at. I'm most fond of our kind of guerrilla marketing campaign, leaving stickers in local businesses, in the bathrooms if they allow us to, or pamphlets there. But it's hard. What kind of efforts in education are you guys making right now, or have you found anything that you think works?
No, we're really just trying to get into it. We do have some pretty good communication channels, newsletters, etc. And tapping into other community avenues. I mean, I think schools I quite like, whilst obviously that's audience is not the primary focus, but the ability of kids to take information home, if you can get through to them, I think is pretty influential. So that's a good way of doing it. So we're out at those sort of health fairs, etc. We have one up in our rural community that's growing year on year, and we have our stroke team out, talking about all the things we're talking about. So it's taking it out to the community, trying to do things. I like some of your creativity. What will land with with people out there? So they're going to assimilate the information, do something about it.
Absolutely. And as we all know, we have talked about in this forum and others, the AHA came out with new guidelines for acute ischemic stroke this year that we're all, myself personally, was super jazzed about. And it really puts some standards that I think is, applicable everywhere, but really hit home for me in a rural area, that all patients would benefit or should benefit from an organized protocol evaluation, that there should be a designated acute stroke team evaluating the patients, and they should benefit from it being multidisciplinary and, trying to prioritize these patients for the fastest care possible. So I'm curious, Dr. Entwistle, who's on your stroke team? What's that patient experience from the time they hit the door? Who do they meet?
Well, obviously they're coming into our emergency department, and we've got a well-organized and trained team. So they'll have the ED provider. So at any one time we've got MD, DO, and PAs. Occasionally it's a nurse practitioner, but more typically it's a PA in the emergency department. And so it could be either that's going to be your first level primary management on the provider side. Then, of course, we've got the emergency department team with nurses, charge nurse, RNs. We've got the techs. We'd have a RT team as well. We'd be calling Code Stroke that brings a whole group of people, including hospitalists. Then, of course, as we've mentioned, we have got our teleneurology service, which is in fact from Savaro. So then we will be immediately bringing people, the team in on that. We've been working really hard on the workflow to really have an impact on daughter needle time. And just if you'll let me, I just have to call out that our daughter needle time average is 27 minutes right now.
That's amazing.
Our fastest is 10 minutes.
Wow.
So it's we're really pretty pleased with what we've done. Now, it wasn't that, sort of 2 years ago, so we've had to work really hard at it. So it's things like how would you get patients into imaging without stalling, and then how do we manage being able to do any blood work we might need to do, etc., in parallel to that. So these are the kind of workflows we work really hard on in order to really improve our daughter needle. So another thing that we've done is in our imaging, we have one of the automated AI services that is tracking those head scans. And we actually have that linked over to UC Davis, University of California, Davis, which is our typical tertiary referral center. Particularly useful for LVO. So if it identifies an LVO, not only will it call it out to our staff so we can get our own radiologists onto it, but it will alert UC Davis, and they know, maybe faster than us, there's potential case for transfer. So that's helped us in smoothing that pathway in terms of the care, the impact, management, and transfers if that's what's required.
Absolutely. I hear you. I just think that those AI apps have been such a game changer in faster recognition for the team, boots on the ground, the team remotely, and trying to facilitate those transfers faster. As somebody who works both in the we are transferring process as well as the boots on the ground, getting patients transferred to me. It has just been such a game changer in facilitating that information and conversations amongst teams, and the one large team, and getting patients where they need to be faster. So people are getting CME for this. So we do have to ask some questions, or I have to ask some questions of the audience. As a polite reminder, to give thrombolytics, the AHA guidelines haven't changed too much on this, so there have been some tweaks, but there are some general guidelines, on blood pressure being within range, as well as glucose, our platelets, INR, things like that. And please don't forget that there are some absolute contraindications to thrombolytics. So when our patient comes in and there's extensive hypodensity, that means they're probably without the window and our risk of doing harm is greater than good. CT with hemorrhage, another obvious contraindication. But some of the other ones that I would like to highlight would be the amyloid-related imaging abnormalities with the use of the new anti-amyloid therapies. This is something that I'm starting to run into more and more. I can't say that I've run into it a whole lot, but it's just something to put on everybody's radar. Dr. Entwistle, I think this is the data you were talking about. That's just so impressive. Like, this is amazing. Also, I'm so impressed with the 10-minute time. There must have been some good pre-notification there.
Yeah. As I say, we work really hard on it, so I wouldn't want people to think that you can just do it like that. It's takes effort, coordination, and clearly teamwork. But we're proud of this. Yeah.
As you should be. And then Dr. Entwistle, if you wouldn't mind speaking more just, to the need of the services needed in all of our rural counties, but especially within El Dorado County, bringing, the care to the patients and where they're at.
Yeah, I thought it would be interesting just to comment. I mean, this is an estimate, if you will, of the prevalence of neurological conditions within our county. 185,000. That's the total population. Some of those are actually the other side of the Sierra Nevada, so they're actually managed by a kind of another hospital over in the Lake Tahoe Basin. But obviously the prevalence is pretty significant. So we think about the number of patients, individuals needing care on an annual basis, and some estimate of the breakdown between stroke and other neurological conditions. And then remember that we don't have a neurologist in the area. I mean, this is a pretty significant burden of the condition. It just gives some idea of the scale of the need that is currently unmet or is only met partially because we're having to refer out. Next slide. But our challenge in that, and I'm sure this is typical of other rural areas, despite that need, despite the fact that it could be a very interesting position because we have an interesting range of neurological pathologies. We had a neurologist here who was a sole provider. I mean, it's old school. Dr. Patak unfortunately passed away a few years ago, but he was willing to serve the whole community any time of the day. He would come in the hospital, he would see people in the outpatients, and for understandable reasons, people aren't willing to work like that any longer. And so you have the challenge of, can you attract one provider to come in and provide neurology services? Is the volume enough to have more than that? It's a challenge. I don't think any one provider would be willing to do it. There are providers in Sacramento County, that's our next county west, Sacramento being in there. But that's where we're referring people to, as well as to the larger tertiary centers. Getting someone into our county is really our goal and challenge. So some of the other things, I mean, we've got to be realistic. What other systems can pay? The ability to provide the support they need. I was just on a call earlier today about providing EEG on an outpatient basis, which we don't currently have. How do we do that? So the modalities of investigation that someone is going to want in order to be willing to provide, so EMGs, EEGs, etc., can also be a challenge. And the last point there, neurologists want to be part of a multidisciplinary team. So we've got to think of all of those things. So next slide. So we're kind of working on this really hard, and we've already talked about what the kind of wait times are, what the drive times can be, and working in partnership with others as to how might we solve that. So next slide. It comes back to the hub and spoke. So if we bring this back to neurology and take that model that we have in mind, what we're currently working on is, don't think for neurology it's ideal to only provide outpatient teleservices, because for some people with some conditions, I think it's really important to be able to provide face-to-face services. Dr. Hoff, you can correct me if you're wrong, you are a neurologist, but it's in some cases you really need to actually see hands-on with the patient. And for patients with more complex chronic neurological conditions, building that relationship, whether it's MS, you get to know the patient's cycles, etc., that can help you a lot in terms of management. And that can be difficult to do if it's only a teleservice.
I wholeheartedly agree, especially within like the movement disorders. I mean, there is something it's hard to replicate on camera. Not that we can't try our best and, do a great job with, again, the resources that we have, but it's different to be, embedded within the community and following those patients over time, just as you said. And again, for some of those evaluations, you do just need somebody in person and right there. Physically touching the patient to feel their tone, it makes a difference.
So we have a collaboration for the issues that we're facing. There are currently 5 hospitals in our broader Sierra mountainous area. Actually, one of them is in the state of Nevada, and the rest are in the state of California, that have formed a collaboration to kind of work on things like this. And so our idea is, might it be possible that we collaborate to have a neurology team that might be, say, doing a day a week of outpatients at Marshall, and then they go to another hospital. So they're kind of wandering minstrels, if you will, to go to different places. And the rest of the time, they're providing teleservices. So we get some physical presence in clinic for face-to-face, and the rest of the time, we're supporting people with tele. So we don't have that in place right now, but that's the model we're trying to work on to see if we could put that together. And then back to that rural health transformation program, can we get funding to test the model out and see if we can make it fly, make it sustainable? But again, we're quite excited. In neurology, because I think it is one of the specialist areas that there's a very strong argument as to why you need face-to-face presence. Some others you could manage pretty much remotely but over tele, but I don't think that's the case for neurology. So that's where we're at.
That's a really exciting model. Instead of doing one outreach in different areas, bringing the physicians and bringing the team to the patients where they get care. I'm really excited for you guys.
See what we can do. Yeah. Next slide.
All right. Back to, we are giving CME, so I'm required to ask questions. A little bit of spaced repetition here. What lab information is absolutely required to give thrombolytics? Is it platelets, glucose, hemoglobin, INR, APTT? While I agree it would be ideal to have all of these, brain is, time is brain, and we want to make things as quick as possible. So I'm going to open up the chat here on my other screen. If people wouldn't mind politely giving me an answer, if there's any guess on what lab is required. I'm going to give everybody a second here. Thank you. Yes, glucose, only lab that's absolutely required. Everything else is nice, but you can just keep her moving if things aren't back, and you can assume things are normal unless you've got reason to believe otherwise. The reason is because stroke mimics, in hypo and hyperglycemia, both can mimic a stroke, and so obviously you want to be treating the right pathology here. Next question. Oh no, we ran into an absolute contraindication to thrombolytics. There's an intracerebral hemorrhage. What tests would you like to do next? This comes specifically from the 2022 ICH guidelines from the AHA. I'm going to give people just a minute here to answer. Do you want to look at the vessels? glucose, inflammatory markers, UDS. For the AHA, it's actually all of them. Most ideal would be all of them. I agree. CTA, if you're already in the scanner, would be the most ideal, but all the information would be great. And then last but not least, what would the next step in management be? Start lowering the blood pressures, load with Keppra, allow permissive hypertension, call neurosurgery, or get that EKG. And the answer is start lowering the blood pressures first and foremost before you even start calling neurosurgery. I would do both in tandem personally, but lowering the blood pressures for that goal of 130 to 150 in compliance, with the AHA guidelines, but also it comes from the Interact 2 and Attach 2 trials that found that 130 to 140 is really the sweet spot. Below 130 can be potentially harmful, especially from like a renal standpoint. So we have talked about this quite a bit, at the hospitals that I serve, boots on the ground, getting timely recognition, and then, having the people available 24/7 in our critical access hospitals can be quite difficult. One place that we've been running into issues has actually been CT techs. In a small critical access hospital that has, 11 beds, paying somebody 24/7 to be in the hospital just in case isn't very attractive for the CT tech, and it's just not realistic to have people living at the hospital. So oftentimes they'll be on call with, requiring them to be at the hospital a certain amount of time. But that, travel time is brain. Getting the lab turnaround time again without access to 24/7 labs can be difficult. And then access to neurology, as we've already highlighted, has been more difficult. I found the statistic very interesting. 55% of rural residents don't have input from neurology during their hospital admission if they're kept locally. 55%. I think that we can do better with, teleservices available now. We have already talked about this quite a bit, Dr. Entwistle. So I'm not sure if you have anything else to input on, what does the team look like? But in the interest of time, if it's all right with you, I'm going to kind of keep moving.
That's fine.
All right. What I would like to talk about, though, is, what does that transfer process look like? And, who is all involved for those, door in, door out numbers for you guys? I know that you said that you're primary stroke center and you collaborate with a tertiary for your comprehensive. What does that transfer process look like?
So as I mentioned, it works fairly well in some instances. So like the LVO example, because they already see it, they might be calling us and say, yes, transfer the patient. It didn't used to be an issue. It's got significantly worse in the last 12 to 18 months. But we will have cases of ischemic stroke, and we may get told to hold the patient and wait to see if they actually progress before we can get a transfer. And we're trying to argue, well, we need to transfer the patient because if it progresses, you need the patient there. We don't want to be kind of trying to then think about it. But the reality for us, and I suspect it's elsewhere, not dissimilar, is that our tertiary centers are hugely impacted. So, for example, just use UC Davis. Any day of the week, there might be 90 patients queued up on gurneys in their emergency department, and they can't even get their own patients in their own ED admitted because they're, playing whack-a-mole with their beds. Because that system is supporting maybe 40, 50 rural hospitals in a very broad Northern California area. Now, it may be the peculiarity of Northern California geography, but that's the kind of issue that we're facing. Is there any, easy solution to it? There probably isn't, but well, there may be. Could we, if there's, I'm dreaming now, down the track, might you be able to do a robotic thrombectomy
Ooh.
that could be remotely managed, and then we could keep patients. As things have progressed, in terms of do you need to do all of this in a place that's got vascular surgery? Anyway, that's not possible today, but there are some interesting opportunities that we might be available, a few years out, some years out, which would be pretty interesting because I don't think the situation is going to get any better in terms of transfer.
I'm with you. I've been following that research and that line of thought for, gosh, probably at least the last year now, and I'm excited about what's to come for helping expand access for thrombectomy specifically. I wholeheartedly agree. So the rural stroke gap continues when patients actually leave the hospital after they get their acute stroke care. Patients in rural hospitals are 24 less likely to go to an inpatient acute rehab facility and are more likely to go to skilled nursing facilities. And patients who get discharged home without any therapy at all have a higher all-cause mortality rate. Patients, regardless of their zip code, who get discharged to acute rehab have better function a year out and make greater functional recovery as compared to patients who go to skilled nursing facilities. Though I do wonder if some of that is self-selected. You have to be good enough to go to rehab and you do have greater rehab potential. But part of that, like I said before, is just access. 25% less likely to even have access to acute rehabs. And then patients who are discharged to SNFs are at a greater risk of being institutionalized more chronically. There's also some benefits just past, to the patient specifically for acute inpatient rehab. Patients who go to rehab are more likely to go home and have more reduced mortality. I thought this number from the Medicare was really interesting. There's 128,000 more days of home time with reduced mortality if acute rehab was available to everyone. And it can truly improve the patient's individual functional socioeconomic trajectory. What kind of acute rehab do you have available in your area, Dr. Entwistle? Do you collaborate with the tertiary facility or is there one available in your county? What does that look like?
Yeah, we do have 3 skilled nursing facilities that we kind of partner with. 2 of them are proximal to the hospital. One is only about 3 miles away. So we tend to use those. Sometimes we do have to refer out. And we do have access to some rehab facilities, but access to those is more of a challenge because, again, they're covering a broader area. But we don't have any that we own ourselves, so we have to wait for access, and obviously that's a challenge.
We run into the same issue with the acute rehab. We have a couple here in town, but oftentimes, my patients will actually decline if they're getting placed and have a bed available because they don't want to be, 4 or 5 hours from home being displaced from their loved ones, from their support network, and they'll actually, choose to go to a skilled nursing facility closer to home. With all the weather that we've been having here, even access to the skilled nursing facilities has been limited. There's a town called Highmore that was absolutely decimated by tornadoes, gosh, a week or 2 ago. And so those patients who are in the skilled nursing facilities had to get replaced out of their local communities and into the surrounding towns, putting more of a stress on those areas too, which I think it's amazing how everyone's coming together, but it has really been highlighting for me, the need for more services.
Yeah, we do have a very effective PT, physical therapy. Yeah. So for patients that are at home, they run a stroke rehab program. So we do make use of that as well, and they're very good at what they do.
Do the patients come to your facility for the rehab in the outpatient setting, or do the physical therapists travel to them? What does that look like?
So we do both. We do have our own health service with PT, so we can be supporting rehab in the home with PT, but we also, bring people to our physical therapy facilities. We have a new clinic we opened about a year ago with some really great equipment to help mobilization, balance, etc.
That's fantastic. Um, as we're, nearing the end of our hour here, I don't mean to be all doom and gloom, and as Dr. Entwistle has shown and demonstrated, there's so many ways that we can close this rural healthcare gap, and there's a lot of promising things, on the docket for the future here. Some of the lowest hanging fruit in my mind, in addition to all of the great work on the boots on the ground, is, establishing a stroke system of care for every state. Right now, it's currently state-based. It's in over 38 states, and Washington, D.C., notably South Dakota, is not one of those states. So I've been working with legislatures to try to get it passed and advocating at the state level. And politics can be messy, but everybody's trying to come together for the patients. These stroke systems of care have been shown to have improved quality and efficiency of care and, overall better outcomes for the patients. It also is a nice avenue for education with our EMS partners, and I would say even education within the communities as well. They also advocate for mobile stroke units, which is great in an urban setting, but those mobile stroke units can look very different depending on where they're placed. This is what I'm most interested in right now, I'll be honest. I believe it's the University of, it's Florida State down in Gainesville has a rural kind of method to their rendezvous with the mobile stroke units. And there's another system out of Texas that does it too, where they have the mobile stroke units placed in, key places around the county. And so for those patients that are further away from the hospital, it's basically transporting a stroke team to the patient, and they'll meet in the middle. And so you can give thrombolytics, before even reaching the hospital. And while the mobile stroke units are very expensive, I think that this is a promising, way we can try to close some of that gap in that access to care. Though I don't think that I guess I don't know how well it would navigate, in the elevation in California and the snow. But I do think, during the better times of the year, it could be beneficial. And then allowing for a tiered approach to stroke, which I know my North Dakotan neighbors do a nice job of. They have these acute stroke ready hospitals to try to get, their rural systems a higher level of care. In states with legislation, the hospital stays are actually cheaper for the hospital systems. I thought this was really interesting. It's between $600 and $1,700 less per year. Because the efficiency of the care given is much higher, and the patients are less likely to die, and they're more likely to do better. As we talked about, time and time again, getting access to people and education, and utilizing teleservices as we're able to try to meet patients where they're at. And with this, obviously very passionate about telestroke and how it can help patients and help close that gap in care. Hospitals that use telestroke have a lower 30-day mortality for stroke patients. There's an increased use of thrombolytics. It's been shown to reduce not just geographic, but also racial disparities, increase the access to clinical trials that patients wouldn't have access to otherwise, and not most notably, but notably, it's cheaper for hospitals. It can save in transportation costs, and in patients who get care more timely, they have a cheaper stay, and they have a reduction in nursing home costs down the road as well. So this is my official call to action for all of my friends here. Please urge policymakers to continue to fund telehealth indefinitely. If your state doesn't have a stroke system of care, or if you're a fellow South Dakotan, please urge your legislatures to get one, and to reach out to your legislatures to ensure coverage mandate for telestroke in all states for telehealth service interventions as a covered service. And with that, we are at the top of the hour, and I wanted to say thank you. Thank you, Dr. Entwistle, for having this conversation with me, and thank you to Savaro for allowing me to give this talk.
Thank you.
Thank you so much, everyone, for attending, and thank you, Dr. Hoff and Dr. Entwistle. There was one question in the chat. Again, I know we're at the top of the hour, but really quickly, one attendee asked, there are other jurisdictions who use the hub and spoke model and have well-established